Hi, my name is Jessica, and I'm here to introduce the action I am seeking to achieve by the end of this semester in regards to the ethical issue I have identified in the beginning of this course, which is the declining health of immigrants in Canada. So, Canada is known to continuously strive and build on its reputation as a multiculturalist country. In addition to this, the nation's population statistics relies heavily on immigration, as 2/3 of the total population is comprised of immigrants. These newly arrived immigrants are known to bring in what is called a health immigrant effect, which is the fact that immigrants' health status is much more exceeding over non-immigrants at their arrival to Canada. Now, although this may sound initially positively appealing, this view is impeded on as health of immigrants are seen to decline based on post-migration factors. And as their time passes in Canada, the decline of immigrants' health status goes to the point where they contrastingly acquire higher risks of medical illnesses compared to non-immigrant Canadians. In fact, the age-standardized all-cause mortality is calculated to be lower for immigrants than Canadian-born populations. And the causes of these mortalities include diseases such as strokes, diabetes, infections, and liver cancers. So based on my research, these post-migration factors have been studied to be of many, but the most emphasized barrier to quality healthcare for immigrants is the discrimination presented by healthcare providers. And this extreme causative factor includes attitudes of insensitivity, unfriendliness, ignorance, inferiority, inadequate cultural competence, and lack of respect. But despite these prejudiced approach towards immigrants, it's made aware that many researchers are based on the health status of immigrants, but not much on the factor of discrimination that greatly affects their health status. Studies on healthcare providers' attitudes towards immigrants and implications for differences in the care is still very rare. Therefore, there's little implementation of what we as nurses can do to stop this discrimination. So amongst the discriminatory attitudes, the specific factor I will be bringing to light is the use of improper discourse in healthcare providers' language and the stigmatizing labels they use against these immigrants. In a study that I had found, the conduction of in-depth interviews amongst adult immigrants and refugee newcomers collects reports that by labeling this population as immigrant itself causes refusal from healthcare providers to welcome this population as their new patients. When healthcare providers stigmatize and label this population as immigrants, their practice entailing their automatic perception is encompassed by the idea that immigrants are too time-consuming, emotionally overwrought, and highly demanding. Therefore, they present the fact that they do not have time for these immigrants. When providers do meet with these patients, the immigrant population perceives their attitudes as abrupt, lacking attentive listening, rushed, too quick to judge, and their concerns disregarded. Immigrants who may speak with an accent believe that this exacerbates the negative attitudes from healthcare providers, as cultural differences between them are brought into awareness. However, instead of embracing and acknowledging these differences to build better partnership, the healthcare providers would then treat this population as stupid, deaf, mentally disabled, or speaking gibberish. Patients would then wonder if their concerns and words were dismissed as exaggerated or psychologically disturbed due to them speaking with an accent or their expression as different from Canadian-born populations. The normalization of readily available labels against immigrants brings forth the preconceived notion of certain behaviors that healthcare providers believe that immigrant populations present. An example of such notions are that some groups are considered clean and pure, while others are dirty and unhealthy. The labeling stereotypes are also very much influenced on the social context of today's world. For example, when we call a patient Chinese woman, we may think that their reason for seeking healthcare is due to their increased engagement of risk behaviors, as they are thought to have low sexual morals and recognized as prostitutes or concubines. Another preconceived example that entails labeling is that oriented individuals are ravaged by disgusting diseases, as they are often presumed to have acquired infections from their homelands. take into consideration the COVID-19 pandemic. It's widely reported currently that the pandemic had in place a tsunami of hate against Asians, as it portrays the term Chinese virus and the unhygienic cause of it from Chinese people eating mice alive. So this labeling, followed by the negative and untrue preconceived notions by healthcare providers, describes what is known as systemic racism, which is a serious healthcare issue that comprises of actions and practices that enhances the unfair inequalities amongst ethnic or racial groups, including immigrants. This systemic racism against the immigrant population is deeply rooted from the Enlightenment pseudoscientific ideology about human race, to which the white Canadian-born populations are presumed as naturally and inherently superior to all other races. This emphasizes the idea that the physical, emotional, behavioral, and social presentation of Canadian-born population normalizes their view on themselves and alienates the ethnical and cultural differences of others. So how am I going to address this issue? Well, within my scope during this semester and my future nursing practices, I am going to sustain the cultural competence needed to critically reflect on how my labels can impact this population. And with that, my action will be to remove all of my automatic labelings that may unconsciously come about in my mind, not only in clinical settings, but in my everyday language. And this will require me to maintain the cultural humility, as I will be mindful of my own biases. And this will also help the clients feel that their health concerns are of importance, not because of where they came from, but because they deserve that acknowledgement. And by removing labels, I will also be acting on my own value of treating others like how I would want to be treated. And I will also be asking each patient as to how they want to be addressed, so that my discourse towards them provides a feeling of respect and autonomy. This allows me to show the clients that despite the differences of race that we may have, I put their health-seeking reasons and themselves as a person first before their culture. And by removing labels, my views of the clients would not be negatively influenced by my own preconceptions of how they behave, what their health-seeking behaviors are, and what their health practices are going to be like. Instead, I'll be seeing to whatever individualized concerns the client expresses in incorporation of their values and beliefs that they each individually carry on their own and not based on my preconceived ideas. And these values and beliefs may or may not be derived in part from their culture and ethnicity, but that would be something that I will take into consideration in my care after it has been officially disclosed by the clients themselves. In order to remove the labels, before each clinical shifts, I will vow to myself that to be mindful and aware of my discourse and labeling on immigrants and its negative impact on their health, as evidence studies that labeling itself against immigrants can create further decline in their health, such as increased mental issues and emotional distress. And with that, I will enter a fresh mind when entering a clinical setting and be mindful to the fact that words have a greater impact than we think on another. This does not dismiss the fact that I will recognize the diverse culture in the healthcare settings, but to embrace and acknowledge these differences and show clients that although I may not fully understand their culture, I am willing to learn and build a trusting relationship with them and be in the center for collaborative decision making. By removing labels in my everyday language, this action will help build a better, collaborative, and trusting relationship between myself and all of my clients. And the clients will feel that their real health concerns are valid and important, and that they are as deserving as anyone else of equal access to healthcare. Removing my labels will also help break down walls of viewing the immigrants as different, foreigners, others, dirty, or time-consuming, and it will help me approach this population with an individualized care that recognizes that their ethnicity does not define their health-seeking behaviors. By removing labels, I would also be more exposed to other possible individual, social, and structural barriers to their healthcare that I can help alleviate them from and increase their quality of life. I will also be practicing culturally safe care, where I address the inequity from inherent power differentials between myself and the client. And additionally, by removing labels in my everyday language, I can set examples for other healthcare providers to do the same in their own practice. And if I were to catch another healthcare provider acting discriminatory towards a client, I will remind them or educate them on being culturally aware and culturally safe as per nursing scope of practice. Overall, my action supports the values set out by the CNA Code of Ethics for Nurses, which is to provide safe, competent, compassionate, and ethical care. So join me and remind yourself that your words are powerful and can be easily changed by being mindful. Because no diagnosis, no surgery, or no medications can heal the detrimental effect that labels can place on this immigrant population.